Hello, everyone. Thank you for joining another Friday VMR. Really excited to discuss today with Rabih. Rabih always uh, hypes up his co-discussants, so I thought I want to embarrass him this time. I'm gonna play
Oh
Rabih
no,
today.
oh
So
no.
for those who don't know, Rabih has been uh, co-discussing on this platform for years. And for those who just see him, just see the end product, which is somebody who knows a lot. So they might think that he is like Einstein. In reality, I would describe him as Arnold Schwarzenegger. Not because he's like a genius, but because he puts in so much work in preparation for every session that you all don't see behind the scenes. And if you just describe him as a genius, you don't see all the work he puts in and all the effort has been put into this work. And other than his clinical efforts, he mentors more than 50 people, I would say, regularly. He knows everything about them, everything they do, what they want to do when they grow up, and he makes sure that they get there. So, Rabih, do you want to say a word?
I'm just so glad you compared me to Arnold Schwarzenegger when Prof Rez, who hits the gym every single day, is listening. That is the single best intro ever. Well, at least I hope Prof Rez. Oh, yes, he is listening. Yes. Prof Rez, your biceps are way bigger than mine. You are much more like Arnold Schwarzenegger than me, but I greatly appreciate the compliment.
That's why we gotta approach use this altered mental status. He has acute encephalopathy, but we'll fix it later.
Youssef, the pleasure is all mine, my friend. Actually, you know what? In our most recent RLR, Prof. Rez, Prof. Rez and I were catching up about CP solvers, and of course, when you talk about CP solvers, you have to talk about Youssef. And we want to embarrass you publicly, him or I, but we're both huge fans of what you've done. But we were especially commenting on your community building and savviness skills. I think people know you as an epic clinical reasoner, but I think your soft skills in and around medicine have really fostered a tremendous amount of community in this space. And I think it's very telling that I've done so many of these discussions with other people, Prof. Rez excluded, of course, who have never hyped me up the way you just did. So right back at you, my friend.
Yeah,
I,
please stop hyping me up, Rabih. It's your turn. You're the spotlight today.
Oh, my man, the spotlight is a sham. It doesn't exist. We're all here hanging out, trying to pass the time, and I'm really glad I get to pass the time with you. But since you took the lukewarm seat of hype, I will also pass on the responsibility of introducing everybody else and remain silent.
Yeah, I would like to give the mic just to Manaswini, who's helping us do scribing today. Manaswini, you want to say a word?
Hello, everyone. I'm so excited for today for Zachariah's case and the trio being here. Super excited.
Zakaria has been a member of CP Solver for a long time. And if you go to YouTube or original videos, you can see his comments on videos from years ago. So he's one of the OG fans. So Zakaria, you want to say a word?
Hi, everyone. Really excited for this case and looking forward to it.
Awesome. So whenever y'all are ready, we can go ahead and get started.
Yusuf, you did that way better than I ever have. Congratulations.
Okay. Really excited for this. So it's a very short first anecdote. And the story is of a 29-year-old male presenting with severe epigastric pain radiating to his back. And I'll stop there.
Wow. Thank you, Zakaria. Rabih, I'm going to go ahead and tackle the first part. And so we hear about a young patient with a significant amount of pain. So the syndrome sounds severe. And just by the degree of pain, you worry about life-threatening etiologies. Like this patient has a syndrome that sounds like life-threatening to their body, that their body is reacting by causing them so much pain. And the location here can be helpful. And you can either take it by location, so start by epigastric region and go from the skin and go all the way in, prioritizing like life-threatening conditions like perforating gastric ulcer, a aortic syndrome, a cardiac syndrome. And I think that's very reasonable, especially in the first few minutes of taking care of this patient, to ensure like, what is going on. And a lot of times you want to treat before you diagnose. So I think in these scenarios, you want to keep in the back of your mind the most morbid syndromes, and this patient is rapidly going to be getting an EKG, a chest X-ray early on, especially if they haven't had a history of this before. We don't have any diagnostic clues, and then you want to consider like aortic syndromes, etc. And I'll be listening about the background keenly to see if there's anything that can help us know what's going on. Rabih, out of all of these syndromes or the morbid syndromes, the fact that the patient is 29, would you prioritize GI over like aorta, for example? Or how does that affect your thinking?
Yeah, I think that the morbidity of whatever is going on now is so high that I'm really not using anything to narrow the DDX, to be quite honest with you. I am paying attention to the presence or absence of nausea, but perhaps we can zoom in on that a little bit later once we get to HPI, because I think it's a subtle thing that might tilt the scale a little bit. But I think the honest answer to your question is nothing about the background information really skews the scale significantly enough in somebody who has potentially a pretty serious illness. So most of my fixation of the data is really just analyzing the foreground information as it evolves, because risk factors are just risk factors, age and otherwise. The disease declaring itself as it talks to us and the way it is through him, I think, is probably the focus of my attention until we learn more. Awesome. All right, Zachary, I'd like to you, my friend.
Wonderful discussion. And again, a very short second aliquot. With regards to the prior history of the patient, he'd previously been well, had no known comorbidities. He had no remarkable family history. He smoked about 10 cigarettes a day, but didn't take any other illicit substances, and occasionally used alcohol on weekends. In terms of the presenting complaint, he reported that he had had sudden onset, severe pain in his epigastric region, radiating right to the back in the middle, but was not associated with nausea, no vomiting. He had no diarrhea or urinary symptoms, and he had no constitutional symptoms either, no dyspnea, cough, or anything else. And I'll stop there.
Awesome. Thank you, Zakaria. I think we hear that there's no major risk factors that we heard of. We didn't hear about like a car accident that happened right before. We didn't hear about a heavy binge drinking or like 17 episodes of vomiting to make us like prioritize like an esophageal rupture versus like an aortic syndrome that we heard about. I think I'm looking out for things. I'm looking out for is this something from the like anterior abdomen radiating to the back? Like, is this aorta, esophagus, or could there be something else going on, like a radiation from the spine, etc.? But I think the morbidity is still there about the abdomen, blood vessels. I think I'm in that space. I think things I can do early on to try to triage this patient. I think vitals will be helpful. Things that I would be looking out for. So I would not be surprised if this patient is tachycardic or hypertensive just from the degree of pain that we can hear. If there is an aortic syndrome, you might have, for example, a wide pulse pressure. So you might look out for that. You might do a pulse exam to see if there's any variability in the pulses between extremities. And all of these are specific but not sensitive. So if you find them, you are closer to diagnosing a syndrome, but if they're negative, you don't necessarily rule it out. And then I think, as we said earlier, like other than that on physical exam, I think early like imaging, EKG and X-ray will be pivotal, all of which are, again, like specific but not sensitive. So if we find something in EKG, good. If it's negative, doesn't mean rule everything out. If we find a widened mediastinum on chest X-ray, that's like 80% sensitive. So if it's enlarged, you're like, okay, I can find some diagnostic value. But if it's negative, you still have to keep going. And I think in somebody who's the syndrome this severe, you're more likely than not to find an answer at the end of our workup. And I think the degree of severity has like diagnostic value. What do you think, Rabih?
You know, and I think that analysis is so superb. And I'll just take a moment to talk about a small little corner, which is the nausea here. Hey, Yusuf, if we were just to play a game of reflexes, when you've seen patients with osteomyelitis of the back or epidural abscess, does extreme nausea strike you as a common feature, or would that surprise you?
Yeah, I would not think that of it as like a common feature.
Yeah, so interesting, right? So right there in the retroperitoneal structures, in the epidural space or in the bones, many patients who come in with osteomyelitis or epidural abscess often have pain, fevers, chills, but they're often not nauseous. And what if we just go right next door to the kidney, say pyelonephritis or a kidney stone? What do you think, nausea or not so much?
Yeah, potential nausea.
Yeah, right. It's such an interesting thing to read. Nausea is probably one of the most overlooked diagnostic clues, in large part because it generally is non-specific, but I think in specific cases it can be. And so, Yusuf, I think, if you invest significantly in this patient's pain radiating to the back, which is not something that I think may be a fixed characteristic of the diagnosis, it may be just a way that this person is manifesting a different kind of disease. Whenever the pain radiates to the back, you're saying, okay, the retroperitoneum is involved some way, shape, or form. And I think it's helpful to classify the organs as primarily retroperitoneal. So this is where the vasculature that you were alluding to is a great example of, and the kidney is another example of, or what's called secondarily retroperitoneal. And when secondary retroperitoneal means that parts of the GI tract or the gynecological tract, only the former is relevant in him, go between the intra and the retroperitoneal. So as soon as you start to go into the second part of the duodenum and the third part of the duodenum, you start to go into the retroperitoneum. So the duodenum and the pancreas are there, and then parts of the colon are there too. And so if you have before you, I'm worried about retroperitoneal pathology because the patient's pain is radiating to the back, is it primary or secondary retroperitoneal? And of course, whenever somebody has associated abdominal pain, you're inclined to think, oh, it's got to be a secondary retroperitoneal because it's going forward to the belly. And that's probably what subconsciously prioritizes pancreatitis in a case like this. But the counter argument to that possibility is that most of the conditions that we associate with GI pathology like this often leave the patient very nauseous, including pancreatitis. And so it's a soft clue to say, the secondary retroperitoneal conditions are often Zofran deficient or ondansetron deficient. What does it mean when you have sudden onset pain in the back and the belly that lacks nausea? And I think that's where I really, really worry about a vascular catastrophe in him. Primarily because the primary retroperitoneal organs, the back, the vasculature, the adrenal glands, tend not to cause nausea, with the only exception being the kidney. So if you're learning something new that has some I'd say mild to moderate predictive powers, it's not steel and stone, I think the first thing you'll do is you might consider organizing pain radiating to the back as primary retroperitoneal or secondary retroperitoneal. And then to emphasize that nausea is a near universal feature of secondary retroperitoneal diseases as they course from the GI tract to the GYN tract. And of the primary intraperitoneal organs, it's only really a consistent feature of kidney diseases. Don't ask me why, I don't know. And so here, when you say that the patient lacks nausea and vomiting, I'm suddenly paying attention and saying, vast majority of cases who have a syndrome like this, usually a GI issue, be it a perforated peptic ulcer or pancreatitis. But the lack of nausea has me intrigued. It doesn't change my management at all, but it certainly pushes me to consider mesenteric ischemia if I hadn't already, but you were well ahead of that thought of it beforehand. But I think going forward, just pay attention to nausea. It's often overlooked and something that may be a subtle clue one way or the other.
Yeah, I love that. Thank you.
What an epic discussion. So onto his physical examination. So just to give you some context, the presenting complaint had actually occurred 2 days prior at a different hospital before he'd been referred to us. So I was actually seeing him about 36 to 48 hours after he'd first developed the pain. And when I went to see him, he looked actually already a lot better. He was 29, BMI about 21 or 22, and he looked quite well. And he said that the pain had already improved quite a bit. He had no peripheral edema, no lymphadenopathy, and he was afebrile. His respiratory exam was completely normal with no distress, and his lungs were clear. And on abdominal examination, there was no distension. It was soft. He reported mild epigastric tenderness, but when you actually touched his abdomen and pressed on it, it didn't actually worsen the pain at all. And with regards to his cardiovascular exam, his capillary refill was 2 seconds. And when I did his blood pressure, it was 87/50. But he actually looked so well that I thought there might be an issue with the cuff, and I repeated it on the other arm, and it had improved a little bit to about 101/54. He had a mild tachycardia of about 105, and his cardiovascular exam was otherwise completely normal, no abnormalities on auscultation, and his JVP was not raised. And then just with regards to some initial labs, his white cell count was 15. That was neutrophilic leukocytosis. HB and platelets were normal. His renal function was normal. And he had a very mildly elevated D-dimer. His liver enzymes were unremarkable, and a lipase was not done. But if it had been done, it would have been negative. His HIV test was negative. And I think lastly, I'd just like to share one picture. 1 second.
We might have to make our friend a Zakaria co-host. I can't do it because of him.
Thank you. I'm just trying to access that share button. There we go. Okay, yeah. So this was the patient's X-ray, and I'll stop there.
What do you think?
I think you see on the right side of the heart, so like the left side of the person seeing, you see like the whole like outline of the lung, which you don't usually see. So you worry about like air in a place that is not supposed to be, maybe in the mediastinum. What do you think, Rabih?
Yeah, my instinct is I can't. This might be some subtle abnormalities. I feel like if I were really in real life, I would probably overlook any finding that this patient has. I don't see any obvious abnormality. Yeah, I'm eager to learn because I imagine Zakaria is showing this for a reason, but that's not something that I caught.
Zakaria, what was the official read, or did you all note on the X-ray?
Yeah, so our official read was that X-ray was completely normal.
You're a sneaky man, you. But hope maybe there's another sneaky element. Maybe this is his read and there's official read notes some subtlety. We'll see.
Thank you, Zakaria. I think we can be reassured, like some time has passed, and our initial discussion about the most morbid diagnoses can go down on the differential. So we're like less worried about an aortic syndrome, for example. Definitely still on the differential, but a severe aortic syndrome or a severe presentation is less likely. And if we were to use Rabih's framework of like primary retroperitoneal or secondary retroperitoneal, i.e., is something in the anterior of the referring back, or is it something in the retroperitoneum referring to the anterior abdomen, for example? I think the lack of tenderness on like very mild epigastric tenderness noted there is making me wonder about something referred or something that is primary retroperitoneal. So one thing I'm considering is there's something like a spinal, like epidural abscess, like you mentioned, is one consideration. Another thing that stood out to me was the low blood pressure on initial presentation. So I was wondering if there's a component of like adrenal disease, either like an infarct there, that would also cause like a neutrophilic leukocytosis or adrenal insufficiency. Although we don't hear about eosinophilia, again, not sensitive. But I think the lack of like an impressive exam is really helpful. So I think where I'm at now is I would want to monitor this patient. I would want to consider getting like a better imaging of the aorta and the chest, like maybe a CT with contrast could potentially better elucidate to see if there's like a structural etiology up front. I think that might be helpful. The mildly elevated D-dimer is very, very non-specific. You can see this with, for example, like dissections, PE, and is very, very non-specific. It does not necessarily have diagnostic value, but it maybe has like wants us to consider, or we would consider like vascular disease. What are your thoughts, Rabih?
I have absolutely nothing to add. I think that's truly superb. You know, as you said from the get-go, the investment in imaging in this patient is going to be very, very high. And in fact, all sudden onset syndromes, if you ask yourself, like, what causes sudden onset anything? It's a sudden onset blockage, sudden onset rupture, or rarely sudden onset discharge of electroactivity, which is not quite relevant in the belly. So things that block and perf are mechanical issues that a radiologist can readily identify. So I think in a case like this, in resource situations that I have, you do go right to the scanner and likely have tremendous clarity. And so the question for me is preparing myself for a surprise, which is that the CT is underwhelming. And gosh, I would be very, very intrigued if that's the case. In fact, I'd be so intrigued I wouldn't know what to do. And so I hope we get there, because I think that would be a fascinating exercise. But if not, I think the CT is probably going to update the problem representation tremendously. So yeah, I'm right there with you. Yeah, I'm really curious how this case evolved.
Yeah, and the other thing that maybe I thought but I did not say out loud is that whenever you have like low blood pressure, you do want to apply the shock schema, because early low blood pressure is early shock. So whenever I see low blood pressure, I'm thinking about literally the word shocked, SHOCD. And so, for example, I'm putting septic less likely, but hemorrhagic hypovolemic also less likely. But we're also thinking about obstructive causes, right? We're thinking about aortic disease, about PE, for example, cardiogenic causes like aortic diseases, and distributive causes like adrenal insufficiency. And we overlay that with the differential, even though we didn't say it out loud. You always want to overlap it and say, oh, which part of this is causing the low blood pressure? Even though it might be truly unrelated due to like lack of PO intake from pain, but I am overlaying that with the differential to rule out the most morbid etiologies.
Yeah, speaking of things that we didn't say out loud, one thing that you said though is I think really important, which is that you didn't fully exclude vascular phenomenon off your checklist, even though the patient has improved. Would you want to zoom in on that? Like, why is that not off your list completely?
I think we're really good at detecting severe diseases.
Yeah.
So a severe vascular dissection, for example, an aortic rupture, we're really good at detecting, but we're not really good at detecting mild presentations of severe disease, like a early dissection and early disease, which we are typically, none of the tests will be sensitive for, or this is where you reach, for example, the threshold or the limits of testing. Like, for example, even with CT, like you're 98%, for example, sensitive for a dissection, but you still miss like 1 to 2% that you will only catch on like CEE or very, very close monitoring. So I think the question is the degree of severity to compare that with the syndrome. And I think given the low blood pressure, I would want to still keep that as a no misdiagnosis because it's actionable and morbid.
Yeah, I agree with you. I think that, in our training, we're taught about the idea that a dissection is a deadly syndrome. And that's true because the dissection can propagate and continue uninhibited all the way from the origin all the way until the end. It can force through a path. But the actual dissection without propagation can be a transient phenomenon. And so there are entities that are actually rupture syndromes in blood vessels that are by definition initially monophasic and dull. So you can have what's called an intramural hematoma, where you just bleed into the media of the artery from the rupture of the vasa vasorum, which Prof. Rez presented a case on RLR where that was the case. And then, of course, a dissection that does not extend presents just like this, abrupt onset pain that then moves away. And then aneurysms do too. Aneurysms frequently have sentinel bleeds. So you bleed a little bit from an aneurysm, but then it's contained, and then you bleed a second time. So, of course, if this patient's pain continues to improve forever until life has played out its course, then a vascular syndrome like the above is very, very unlikely. But it's only been 2 days. And so on day 3 or 4, something disastrous could happen. The dissection could extend, the hematoma could extend. So I'm really glad that that's not off your list. And I think even if it's not the case in this circumstance, it probably should take up a decent amount of space, just given the associated morbidity. All right, is that X-ray really normal, or is it abnormally normal?
Yeah, I can promise that X-ray was completely normal.
All righty.
And just to add
I
on a
don't
few,
trust you.
just to add a couple of things from questions in the chat. The patient had a normal body habitus, was not tall, no thin fingers or anything at all, and did have normal capillary leafal in both arms. So I'm going to first start by sharing a very basic echo, just as I think it's always nice to see how someone's heart's contracting, and then we'll move to a little bit more imaging. So this is this patient's basic parasternal short axis with his left ventricle and his right ventricle. I'll play it one more time. And then I'm going to start setting some further imaging. So starting off with the different view of his CT. And then I'll share a couple of different views as well. Play different view one more time. There we go. So I'll stop there. Happy to play any parts if you'd like.
Rabbi, I might lean on you on this one. I don't think I see like anything like any large dissection, but or any pulmonary etiologies, but I'm not sure if it's like a subtle finding that I missed.
Yeah, I think it's really difficult, honestly. I think I didn't catch anything in the chest, but Yusuf, sorry, Zachary, do you mind playing the axial cuts again one more time?
Oh,
Yeah, there you go. I didn't see anything in the chest. I'll look one more time. See the trachea, the esophagus, the bronchi. I don't see any airway. Shouldn't be. The heart size looks normal. I don't see a pericardial effusion. The liver starts to creep in now. The stomach is full of contents in it. I see the right and left kidney. Yeah, I don't. Sorry, say that again.
Is there any specific part you'd like me to replay?
No. Yeah, I am. Yeah, I'm. I don't know if there's in front of the right kidney. There's a little bit of a haziness and a hypodensity right anterior to the kidney. I don't know that. I have to look up and down to see that. Maybe you can play the other views just one more time.
Sure, absolutely.
Yeah, these are all non-con, and I think this is a contrasted view. Yeah, I didn't see that. Yeah. Can't tell on that kidney if there's a. Yeah, it's probably not a hypodensity in the kidney. Yeah. And it's very hard to tell. Yeah, I think, the reason I'm staring at it is the probability of this showing something is so high. And we have already had Zachariah fool us, but I think I'd scrutinize this up the wazoo. I think the main limitation for me is that the only imaging that I'm noticing has contrast is what we're seeing right now. The other images don't. And I think that's making my ability to pick this up harder. But while I've been blabbing, Yusuf, anything that caught your eye?
Not really, not really. Zachariah, I can't wait to learn from you or show us.
So can I actually suggest, it's a relatively short, but I think important case. Before we continue, what do you think about the breakout rooms for a couple of minutes, just to discuss? And I'll add one more piece of information before we go into that breakout room, if you think that's okay, that the patient's CK is 6,000.
Okay. And Zachariah, how many aliquots do we have left after this one?
So actually, after this adequate, a little bit of further discussion. I have 1 or 2 questions, and then one final adequate that will reveal the final answer.
Okay, sounds great. And then do we get a read of the CT, or do you want them to just analyze the what we saw?
Yeah, I'll give the read as soon as we're back.
Okay. Welcome back, everyone. We'll go ahead and get started with the discussion. I think one thing I was thinking about was that the creatine kinase was elevated, and the question is, where is the CK coming from? And one thought I had is, could this be from the heart? Like, you know how we have CKMB released from the heart, and creatine kinase can include CK. So one thing I would want to rule out is like a myocardial infarction. To think of an MI, you want to think about EKG, troponin, which Zakaria is probably going to give us soon. But this is not an MI in a 60-year-old where, oh, okay, it's the most common cause of MI is atherosclerotic vascular disease. This is MI in a younger person. So the question is, if it is an MI, even if it is an MI, what are the causes of MI in a younger person? And that includes the number one is dissection. So could there be a dissection that we haven't found causing an MI? For sure. That's one. Congenital hypertriglyceridemia syndromes is another one. Embolic causes are number 3. But I think my number differential 1 and 2 are MI and dissection still. And things that I would want is 1, like an EKG and a trope, of course. And 2, I loved Mengyu's idea of talking to radiology, of asking them, hey, I have a CT without contrast. Do you think this was appropriately timed, or what do you think this? How well is this picture to rule out a dissection? Because I think you, with the hypotension, the elevated white count, even though it's not non-specific enough, but in the past they used to diagnose MIs and strokes with like an elevated white count as one of the markers. Like, so that's where I'm at. I'm still in the very morbid diagnoses. I'm thinking MI and dissection. What are your thoughts, Rabih?
Yeah, Yusuf, I'm right there with you. I love how you use all that. And I'll just say that when you get a surprise CPK like this, and I would say it's a surprise because most of the time when you have a CPK this high, it requires many muscles to be injured at the same time to cause this degree of CPK abnormalities. And so I would say that whenever you have a focal syndrome plus a very high CPK, I think you should make sure that it's not the heart, though. I think it would be pretty unusual if you think about the number of people who have myocardial infarctions who are detected with a high sensitivity troponin, zooming in on small damage to the heart, let alone having to have a macroscopic event of another enzyme. But I think there's syndromes where you can get such severe focal muscle necrosis that this might push us to say, wait, hold on, does he have a lumbar paraspinal muscle issue? And that's not part of the CT scan that I'm naturally drawn to or scrutinize. So what I would go back is I'd go look back at the CT and be like, were his lumbar muscles okay? The only CPS case that I think Gurpreet Dhaliwal has ever missed in a published case world is a case of what's called lumbar compartment syndrome. So that's a thought that crossed my mind. But in reality, this test is mismatching the syndrome it usually is found in. It's usually found in the diffuse muscle ache syndrome. And so when we're trying to merge it into a focal syndrome, you realize, well, these two things don't usually fit. So it might be just complete noise. There might be a lab error, or there might be a history error. One of those two things are happening. But if you are trying to solve a focal abnormality with a positive CK, um, is it a distractor? Is it completely noise? Or is it extensive disease of a very specific muscle group? A horrific myocardial infarction, hopefully an EKG before an X-ray, or a really extensive necrosis of a focal tissue, essentially compartment syndrome. Zachariah, you have us very, very intrigued.
Big discussion, and honestly, I almost don't want to share this with you, but I will share the final diagnostic test that revealed the answer.
Ouch. All right, Youssef, go for it.
Really bad. So I'm gonna say no. It looks like very marked ST elevations in V2, V3, V4, V5, with biphasic T wave and like V4, V5 or negative T wave. And then I'm looking for reciprocal changes potentially as well. Let's see. Maybe in 3. So I'm really worried about an infarct or an MI, and I'm thinking about the secondary causes that we thought about before as well.
Yeah, this is really sad and hard to see, honestly. I think, the timing of the infarct is also inconsistent with the 2 days because you're starting to develop what appear to be Q waves in the precordial lead. Yeah. So, I think that the as you mentioned, Yusuf, this is the beginning of the journey. I think that this is likely an occlusive myocardial infarction. The question is why, but I think first, of course, management is key.
So exactly right. Just to go back to the CT scan, I can tell you that the read from the radiologist was that it was completely normal with no evidence of an aortic dissection or any other pathology noted. And the patient unfortunately suffered a severe left anterior descending artery occlusion myocardial infarction. And the reason you see those Q waves is that is what happens when someone has a myocardial infarction and does not get treatment until about 48 hours after initially having the presenting symptoms. And yeah, I'll stop there to say that just in terms of the workup of the patient, his HbA1c was normal, had a very mildly elevated LDL, but the triglycerides were normal, and he has no history of any other substance use or any other identifiable risk factor for myocardial infarction, besides just being somebody who smokes about 10 cigarettes a day and seems to have perhaps some unfortunate genetic predisposition.
Well, thank you for sharing, Zakaria. I think thinking through the secondary causes with you, I think one of them we said was dissection. Dissection, you can see it on a CT, and then if this patient actually gets a catheter, they might like put contrast there, and they might be able to see the section there. Or if there's a spontaneous coronary artery dissection, they will be able to see it on catheterization. Same for like embolic disease. A lot of times they might see angiographic thrombus, for example, or multiple vessels on the cath. Vasospasm you think of as well. We didn't hear any like triggering factors. Usually it's not like severe MI. Usually it's like reversible. Usually doesn't get to this extent. And then vasculitic etiologies, we wouldn't necessarily, not saying we need to work them up here, but that's the other thing you would think of for an MI in a young person. There are some like genetic etiologies that cause this, like neurofibromatosis, for example, like subtle, like that are relatively common and cause like vasculitis on the vessels that supply the heart. And I think at this point, you would want to treat, and if you find etiology, you do, but if not, then you do it supportively. And this is an area of medicine where we still don't know why some patients develop like MIs at a younger age, including like soccer players that we've seen before, right? Iker Casillas had it. Yeah, Rabih, what are your reflections?
Yeah, I think I think this is the beauty of this community is all of you are, or most of you are probably surprised that the EKG came after a CT, but I think medicine is really hard and you can see how in situations this could happen. And the reality is if you can see it, it's because you're not looking enough because it happens a lot. And acute myocardial infarction is one of the most common causes of malpractice litigation in the United States, missing it. So this is a story that has been written before. It's tragic that we're seeing it in front of us right now. So I'm really curious to learn from Zachary. I have nothing to add to this as profound reflections on what his take on the sequence of events was and what we can learn from how they unfolded, and also how the patient was treated. Did he get a cath, or anything you can enlighten on the sequence of events and then the steps after this case was the diagnosis was sealed, Zachary, for us to learn from?
Yeah, so I think honestly, a lot of my thoughts on this case, I probably will have to leave off a public platform. I probably need to debrief, but I can say that it was put in the chat already. But there's a famous ECG blog by Dr. Steve Smith, and in it he says that the only thing worse than having the second worst thing is a young male having a myocardial infarction. And the only thing worse than that is to be a young woman having a myocardial infarction. So I think just a tragic case. Patient was thrombolized and is currently in cardiogenic shock under butamine, awaiting cath.
Yeah, I appreciate the truth is I appreciate what you're saying about being off a public platform, and I think that's very important. And I will also emphasize to all of you at the same time that statistically speaking, all of you are likely to make a major error, huge error. Hopefully not of this proportion, but it's going to happen to all of you. And I hope the only thing that's indefensible, in my opinion, is that when it's done out of negligence, and I think that is inexcusable. But I think, gosh, as we don't know the details, Zachariah, so I think all of us are analyzing this case from a distance. And for me, the default is to start with the presumption of there not being any negligence. Of course, unfortunately, negligence in the medical field is a pervasive phenomenon as well. But just to help soften the blow for everybody else, something like this is going to happen to you. And if by definition you are here, the chances of you being negligent are 0%. You're going above and beyond to learn more. So I'm sorry this happened to this young gentleman. I'm sorry he continues to suffer the consequences of it. But what an incredibly powerful lesson to share with us in the way you did, to sort of put in front of us that normal X-ray, put in front of us that normal CT scan, and all the investigations that were done that were not elucidating this patient's issue. And a simple bedside 1-minute procedure captures a life-threatening diagnosis. And for me, that just emphasizes that one beautiful thing about this test. This test is invented over 100 years ago. And to this day, it continues to outperform almost anything else in terms of its ability to detect such a deadly disease. So, yeah. Any reflections you want to impart upon Zachariah before we learn from Youssef's take and Kritika's take?
Nothing at all.
All right, Youssef, final word to you, my friend, before we hear from Kritika.
I also think, Rabih, that I hope that the degree that now we rely on providers identifying subtle EKG changes to identify this early disease. In reality, in the future, if the troponin becomes high sensitivity, point of care, and cheap, you have less reliance on individuals and more reliance on the system. And I think that's something that we need to do and humanity needs to do. And I think that it's not hard to imagine a place where it's cheap and everywhere. And I think that's going to be in our lifetimes. And I'm hoping for that.
A powerful point in need of technology coming to save us for our egregious errors. Kritika, mic to you.
Thank you for such an important case, Zachariah, and amazing discussion, Dr. Rabih and Youssef. So today we had a 29-year-old male with a history of sudden onset severe epigastric pain that was radiating to the back. So Dr. Youssef mentioned that in case of epigastric pain, some no-miss life-threatening etiologies we need to consider are perforating ulcer, aortic syndrome, or cardiac syndrome, where treatment is most important before we go for diagnosis. So firstly, we need to triage the patient based on the vitals, the EKG, and any supporting imaging. And as for the symptom of nausea, Dr. Ravi mentioned that we need to consider two causes, which is a primarily retroperitoneal cause, a secondary retroperitoneal. Primary retroperitoneal is organs like kidney, but that is an exception where you do see nausea or other vasculature or adrenals. And secondary retroperitoneal structures include the gastrointestinal structures like pancreas or second part of duodenum, where nausea is common. So that will help us localize the site. And coming to the hypotension part, this patient had hypotension, and some of the things that we need to consider comes with a pneumonia called shock, that is sepsis, hemorrhage, obstructive, cardiogenic, and distributive causes. And in this patient, we had an elevated CK. So this high degree of CK we can consider in any local muscle necrosis or any lesions like compartment syndrome or myocardial infarction. And my takeaway from this case is before we did all of these investigations, I think ECG would have been a much simpler thing and we could have closed the case there. Thank you for the case.
So crisp and so spot on. Thank you so much, Kritika. That was absolutely outstanding. Youssef, take us home, please.
Thank you everyone for joining. If you want to present a case, you can do that on the website. You just go to quickerproblemsolving.com, and then at the top you just hit morning report and you just click present a case, and somebody will be matched with you to help you organize it and present it. Doesn't have to be the zebra. It can be something really common like a migraine. We'll also take that. We just love learning and teaching and thinking about issues so we can treat our patients better. So thank you all for joining and happy Friday.